is already developed, and cell reproduction is not the issue. Now it's growth. So they're like little tiny adults growing, rather in the first trimesters when we really want to avoid radiation because cell reproduction is so frequent.
Isaac?
I'm E.G. Worcester. We heard earlier about ascending thrombophlebitis and management, including saphenofemoral disconnection and then whatever, perhaps thermoablation to the long saphenous vein. If the clot hasn't reached the saphenofemoral junction, would you still advocate saphenofemoral disconnection in this situation?
Well, sure. You're right there, because if you're going to take this approach to get rid of the clot and ablate the vein, which you can do in less than an hour, I think we would all agree. So basically, you've performed a curative procedure on this patient. So we would, when we're there, we would resect all of the visible saphenous vein from the saphenofemoral junction distally, and then ablate the rest.
The point I'm making is that if you're not there, should you be there at all? I.e., could you go up from below and deal with the unthrombosed bit of the long saphenous and do it all from below?
Well, the question is, how would you get the clot out from below through a very small puncture site?
Okay.
Tony, what's your time limit on dealing with acute thrombophlebitis? Because I don't ever seem to see them until about 3 to 4 weeks.
Days to a week. Yeah, I mean, at 3 to 4 weeks, you're in a chronic situation, and I think you're stuck with that.
Andrew McKervin, the gentleman there who's got the microphone. Yeah.
Now, can you go back to the pregnant patients? What are you using are you using catheter-directed lysis for those patients? Are you using trellis or angiojet? And if you're using catheter-directed lysis, what agent are you using, and is it detrimental to the fetus?
Well, we don't know that any of those agents are detrimental to the fetus. We're using TPA, incidentally, and we're using low dose, but we use low dose on everyone. Low dose being a milligram. If we're going to give an infusion, a milligram an hour in 50 to 100 cc's. But yes, we're using the trellis catheter preferentially, or we're using pharmacomechanical techniques preferentially, and use the trellis. We use ultrasound accelerated thrombolysis for any residual thrombus, or if we have to dissolve clot from the ankle to the popliteal, we'll use the ultrasound accelerated lysis. We will touch up any residual segmental thrombus with the rheolytic thrombectomy. So we're using all of those techniques, and if we're using rheolytic thrombectomy, I suggest that you put some TPA into the solution, because when you force your saline into the thrombus, if you have a TPA in the saline, that will bind to the thrombus, at least to some degree, and accelerate lysis of residual thrombus after you're finished.
Tony, I want to make a comment. I had to command all the time my tongue while you were talking. I mean, we are recommending right now a technique with limited technical expertise. So my advice is for all of you attending us here, that whomever wants to start with that you get the expertise from someone who is experienced. Would you agree, Tony? How long does it take to learn? I mean, it's tricky. I mean, being an interventionalist on the arterial field took me some time to understand the differences in veins and valves and getting the systems into the vein.
Well, that's a very important point. I mean, it's so important. I would just underscore it. What I think has hampered this whole guideline development process is that the critics of the catheter-based techniques don't use it. And then when they have a particularly difficult case in their institution, then it will be referred to people who have no experience